Today's topic is irrigation in endodontics. So irrigation is one of the important part of root canal treatment. So we will see about what are the different irrigation material and irrigation techniques available to improve our root canal treatment. So from first one introduction of the topic, then the properties of an ideal irrigating solution, then what are the functions of an irrigant, then classification, then different irrigating solution, overview of irrigants and different or variety of techniques and devices used for irrigation. So an important objective of endodontic therapy is the removal of the necrotic infected pulp and debris from the root canal system of the infected or non-infected teeth. In order to accomplish this objective, it is essential to use an irrigating solution or a combination of the solutions during cleaning and shaping of the root canal. Failure to use an irrigating solution during the cleaning shaping will considerably result in leaving behind the debris inside the root canal, blocking the canal, and ultimately leading to the failure of the endodontic treatment. Hence, obtaining an optimal level of disinfection is the utmost important part of root canal therapy. So what are the properties of an ideal solution? First one, the irrigant solution should have tissue dissolving properties of both organic, that is bacterial and pulpal tissue, and inorganic material like smear layer. Then it should have a sterilization or disinfection property, that means it should have antimicrobial activity. It should be able to flush gross debris accumulated during the debridement. Then lubrication of the canal for ease of instrumentation. It should have low toxicity, so that doesn't harm the periradicular and gingival tissue when it comes in contact with them. It should have low surface tension, which allows it to flow into the inaccessible areas where cleaning shaping material cannot reach. It should have antiseptic property and it should help in removal of the smear layer. So these are the five cardinal functions of the an irrigating solution, which are considered to be important, so that it should provide an ultimate final clean root canal. So first one, it should have antimicrobial activity, lubrication to allow ease of cleaning shaping and bleaching action, then dissolution and debridement and removal of smear layer. So what are the factors which modify the activity of irrigating solution? First one, concentration of irrigant. Then what concentration you are using, where low concentration or high concentration. Then contact time, means how much time the irrigant solution is remaining into the root canal system. Then presence of any organic tissue which might affect the activity of the irrigant. Then how much quantity you are using to irrigate. Then what type of needle you are using? It includes the gauge, location, the type of the needle, the system which are used for the needle. These are the things which affect the needle which are used for irrigation. Then surface tension of an irrigant, temperature of the irrigant, frequency of irrigation, level of observation. Then how is the canal diameter, whether it is narrow or wide canal, whether it is straight or coarse canal. Then what is the age of the irrigant, whether it is freshly prepared or it is stored into the stored and then it is used after many days. So obviously the age of the irrigant will affect. Then coming on to the classification, stock based on the chemical activity describe the irrigants into water-based, acid-based, alkaline-based, oxidative agents, gelating agents, normal saline and anesthetic solution. So water, which was used as one of the important irrigant during 1940s, so commonly used during endodontic irrigation, a stream of hot water of temperature 140 to 176 degree Fahrenheit were used to remove the or debris inside the root canal. Then acidic like citric acid and phosphoric acid, alkaline based sodium hypochlorite, which is available in various concentrations, sodium hydroxide, urea, then potassium hydroxide. Then oxidative type of irrigants, which includes hydrogen peroxide or glyoxide, chelating agents like EDTA, normal saline, and also anesthetic agents. So these irrigants are used in various combinations like hydrogen peroxide and sodium hypochlorite, glyoxide and sodium hypochlorite, RC prep, which is EDTA and sodium hypochlorite. So what is in the classification we saw many irrigants are available, but how do you choose the irrigant? Which irrigant is useful for which type of canal? Currently, as there is no such a single irrigant which can fulfill the properties of ideal requirement of an irrigant solution, so we have to rely on combinations of various irrigants to fulfill their requirements. Now coming on to the first one, hot water, as I told, the stream of hot water 140 to 170 degree Fahrenheit was discharged using an insulated syringe and was the first irrigant used in endodontics. It is used also mainly for flushing the root canal. Lorixai et al. In 1955 stated that it is used, showed some periapical bone regeneration after mechanical irrigation, mechanical instrumentation using water as an irrigant solution. So it is not very bad. It obviously provided some positive results and reduced the infection in the root canal caused by infected bulb or necrotic tissue. The next one is the normal saline with 0.9% water weight or volume. pH 7 is used as a commonly used irrigant even in today's era in endodontics. Its primary action is a flushing. It has mild action as an it has very mild action. It is usually used as an adjuvant irrigant and also as a final irrigant, final for use for final rinsing of the endo root canal system during cleaning schedule. So advantages is that obviously it is very bio-friendly. There is no adverse reaction if extruded beyond the apex because the osmotic pressure of the normal saline is same as that of the body fluid. Whereas the disadvantage, it doesn't have any antimicrobial property, but it is the however, followed by use of ultrasonics as an irrigating equipment, it has reported to be almost effective as sodium hypochlorite 0.5 to 2.5%. But it is incapable of removing any smear layer, doesn't possess any dissolution or disinfecting properties, cannot clear the microbial flora from the inaccessible areas like accessory canals. Then next one is the sodium hypochlorite, which is the most popular irrigating solution. It is a clear pale yellow proteolytic reducing agent with a strong odor of chlorine. It is miscible with water and gets decomposed by light. In 1915, during World War I, Henry Dackin first used this solution in 0.5% concentration for the treatment of infected wounds. And because from that day, it is also known as a Dackin solution. But Dackin solution is just 0.5% concentration of sodium hypochlorite, not any other percentage. So don't get it confused. Only Dackin solution consists of 0.5% sodium hypochlorite. So this is a highly alkaline material liquid with a pH of 11 to 11.5. Sodium hypochlorite is buffered with sodium bicarbonate. 5% solution consists 5% of the available chlorine is present according to Grossman. So commercially available sodium hypochlorite is known as Chlorax, which the pH ranges from 10.83 to 10.98. The composition of Chlorax is sodium hypochlorite 5.25%, sodium carbonate 0.2%, sodium chloride 4%, sodium hydroxide 0.005 to 0.015, and water around 90%. There are two methods of manufacturing this sodium hypochlorite. First one is for chlorine plus sodium hydroxide. It provides sodium hypochlorite plus water and sodium chloride. And second method is electrolysis of saturated brine solution to produce sodium and chlorine ions. How do you store and handle this material? You should always store this material light-proof opaque glass or polyethylene away from the light. Stability is reduced by any lower pH, presence of any metallic ions, exposure to the light, open containers, and high temperatures. Then what are the properties of sodium hypochlorite? First, we had as an antibacterial property. It has a strong dissolution property of the soft organic tissues. Then lubricant, bleaching action on discolored teeth, and increased permeability into the dentinal tubules. Sodium hypochlorite exhibits a dynamic balance as shown by the following reaction: sodium hypochlorite plus water with sodium hydroxide plus hypochlorite ion plus sodium plus hydroxide plus hydrogen ion plus hypochlorous acid. So the pH whenever in water sodium chloride ionizes to produce sodium ion and hypochlorite ion that establishes an equilibrium with hypochlorous acid HOCl. So between the pH 4 and 7, the chlorine exists in equilibrium predominantly as hypochlorous acid, the active moiety, whereas when the pH is above 9, it is more alkaline. Hypochlorite ion is less effective than undissolved hypochlorous acid. So hypochlorous acid disrupts oxidation. This hypochlorous acid, which is mainly produced, is responsible for the action of the sodium hypochlorite, and it disrupts the oxidation, phosphorylation, and other membrane-associated activity as well as DNA synthesis. So, the solvent action of sodium hypochlorite. Grossman and Neyman more stated that more effective pulp solvent than potassium hydroxide, hydrogen sulfide, sodium hydroxide, hydrochloric acid, then PAPIL. So 2.5% solution has better cost, is a powerful solubilizer, and according to Morgan, 80% of the tissue solvents is achieved using 2.6% of sodium hypochlorite. And then coming on to the antimicrobial efficacy, so 1% sodium hypochlorite is found to kill both the bacterial spores and HIV over a period of 30 minutes. And it all stated that 1 to 5% of sodium hypochlorite is effective against even Candida albicans, which is the most important microorganism against the fungal infection. Then O'Hara et al. 1 by 10th concentration of sodium hypochlorite stated that it is effective against even several anaerobic bacteria. However, dilution below 1 by 10 was completely ineffective. So some concentration which need to be maintained. And Kuruvilla and Kamat stated that 50% reduction in the microbial count was seen when 2.5% sodium hypochlorite was used along with the synergistic response of chlorhexidine 0.2%, which led to the 80% reduction in the microbial count. So in present, how much time we need to keep the sodium chloride into the canal to achieve this antimicrobial property? In presence of smear layer, 1 hour sample provided one samples were taken from after 1 minute, 5 minutes, and 30 minutes. They all provided a positive results. That means reduction or removal of the smear layer was achieved. So if smear layer was removed 5% sodium, and complete antimicrobial activity is achieved at 15 to 30 minutes interval when sodium hypochlorite found to be to clear the coronal and the middle third of the canal better than the saline. However, apical 3 had no difference, even 5% for the 5% sodium hypochlorite activity. So it is more effective, obviously, in the large diameter canals, because in the narrow canal it has to reach the narrowest part of the canal, and unless and until it comes in contact with the root canal surface, it cannot remove it. So that is why larger diameter canals obviously will have better positive results compared to the diameter canals. Then it is more effective in cleaning isthmus. Zebram removal stated that the removal of the debris is dependent on the canal diameter, pressure of irrigation, and diameter of the irrigating needle. Reported least diameter of number 40, preparation of the root canal. Then Marwan Abon stated that the least diameter was at least 25 number to be have to achieve effective properties or effective antimicrobial effect of the sodium hypochlorite. Then what is the effect of temperature on the sodium hypochlorite? So collagen dissolving effect, Cunningham and Balphigian showed that the increase in temperature from 22 degrees centigrade to 37 degrees centigrade of a 2.6% solution increased the tissue dissolving properties which were equivalent to 5.5% solution at room temperature. And the bactericidal effect was shown to be, that warmed 2.6% sodium chloride was effective against E. coli, Streptococcus suis, Bas, B. subtilis spores, P. vulgaris, Streptococcus aureus organism early as 45 seconds. The spores took the longest time for destruction, around 180 seconds compared to 600 seconds for the solution of 22 degrees centigrade. So Ilbersh and Murphy demonstrated that even peppers of sodium hypochlorite exert strong bactericidal action. So this was the temperature effect of the rising temperature. So slight warming would provide effective effect as well as the higher concentration of sodium. When you are using some lower concentration, the warming up of the solution usually will provide the action similar to the higher concentration solution of sodium hypochlorite. Then what are the effects of surfactants on the sodium hypochlorite action? So obviously surfactants helps in reduction of the surface temperature, surface tension. The reduction of the surface tension is obviously useful in reaching the narrowest and the most difficult areas of the root canal. So Sania, Marshall and Rosen, Salazar and Brilliant Ram stated that the little or no spreading of the irrigate occurs in the canal smaller than size number 40. So reduction in surface tension would allow more for more intimate contact of the irrigant solution and between the irrigant and the root canal surface. Abu Ross and Patonai stated that lowering the surface tension 70.9 to 69.8 millinanometer for newtons per meter for so 5.25% required when polysorbate 80 was used. So Cunningham and Associates stated a use of ethyl alcohol to for the reduction of surface tension before it, along with the usage of sodium chloride. Cameron stated fluorocarbon surfactant fluoride FC99 for the reduction of the surface tension of the root canal along with the sodium hypochlorite. Then ultrasonic activation of the sodium hypochlorite includes obviously ultrasonic activation has nowadays it has become one of the most integral part of the root canal treatment and irrigation system. So it has shown to accelerate the chemical reaction by creating a cavitational effect and thus achieving a superior cleansing action of sodium hypochlorite. Then what are the effects of sodium hypochlorite on the composition and structure of the dentine? So how does it affect the dentine? Sodium hypochlorite treated dentin enzyme demonstrated a slow and heterogeneous renewal of its organic phase, leaving calcium hydroxyapatite and carbonate apatite unchanged. So it doesn't have any much difference on the inorganic part of the root canal. 5% solution of produced an alteration in the dentin collagen and glycosamine glycans and hydroxyapatite. Sodium hypochlorite causes concentration dependent reduction of the elastic modulus and flexural strength in the root dentin. So this was actually few effects observed for the sodium hypochlorite composition of sodium hypochlorite on the dentin. So how does is the bonding of the dentin affected if sodium hypochlorite is used when we are using some other um, resin-based sealers during obturation? Does the use of sodium hypochlorite affect the bonding of the dentin? Because nowadays resin-based sealers are in trend, and that is why whenever the sodium hypochlorite is one becomes one of the most popular irrigants, so one should have knowledge about its activity on the bonding of the dentin. So increase in sodium hypochlorite application time resulted in a progressive decrease in the shear bond strength for both the dentin adhesives. After hypochlorite treatment, dentin bond strength and marginal vibration has significantly decreased. Shinohara et al. Found that depending on the adhesive system used, the application of sodium hypochlorite also increase the magnitude along the dentin margin. So it has a deteriorating effect on the bond strength of the dentin. So obviously, whenever you are using some irrigant solution, try to use saline as a final irrigant to remove all the effects of the sodium chloride. Then how does the penetration of the dental tubules seen with the sodium hypochlorite? Higher concentration, better is the penetration of the dental tubules. So shortest penetration is seen around 77 mm when 1% sodium hypochlorite was kept in the root canal for around 2 minutes at room temperature. And if the same concentration is increased up to 6% and the application time is around 20 minutes, the highest penetration is seen around 300 millimeters at a temperature of 45 degrees centigrade. So as the concentration increases, the penetration also increases and the contact time is also very important to achieve the more penetration so that it means it has the property to reach the accessory canals where normal mechanical feeding shaping doesn't achieve. The use of specialized irrigating syringes, the newer specialized side vending endodontic syringes are mostly safer to use with sodium hypochlorite with a narrow diameter 32 gauge. Aids in getting the irrigant closer to the apex also helps in moving sideways rather than crossing the apex. and causing some sodium hypochlorite accident. So these are the properties of sodium hypochlorite, effects of the sodium hypochlorite as an agent. What are the adverse effects of sodium hypochlorite? First and foremost, we need to know about is the sodium hypochlorite accident, which occurs because of the improper irrigating technique used during the irrigation of the canal. So the inadvertent injection of the sodium hypochlorite into the soft tissues can elicit a violent and a frightening response. But no one actually does this. The only accident can occur is during the this accident can occur if the doctor is unaware with the syringe which is used for sodium hypochlorite accidentally is thought to be used for as a local anesthetic solution. So always keep the sodium hypochlorite syringe away, and it should have a proper marking that it is an irrigant solution, and one should be careful not to inject the sodium hypochlorite directly into the soft tissue. Then another injury can occur during is the irrigation technique of the sodium hypochlorite. When we are irrigating the canal, if the needle accidentally gets wedged inside the walls of the root canal and you forcefully irrigate the solution inside the root canal, so that forceful irrigation can lead to crossing of the sodium hypochlorite beyond the apex and causing this hypochlorite accident. So these are the two possible causes for sodium hypochlorite accident. So what is the mechanism of injury here? So the mechanism of injury is usually the primary oxidation of the proteins followed by the inflammatory reaction from the body. So wherever the sodium hypochlorite is coming in contact with the soft tissue, the primary oxidation of proteins of the tissue occurs. This response is similar to that of the angineurotic edema with the release of histamine or histamine-like substance, which leads to vasodilation with the subsequent transudation of the plasma accompanied by hemorrhage. So this is a picture where it's showing the patient which has undergone the sodium hypochlorite accident. So the amount of destruction will depend on first the host response, then volume of the irrigation, then what concentration of irrigant you have used during that accident, then temperature of the irrigant and the spread of the solution. So Sabala and Cowell have stated some events, a sequence of events where we can suspect that these events if you are experiencing during the treatment, that you might suspect that this might be a sodium hypochlorite accident. So first one, the pain, excruciating pain within 2 to 5 minutes of the accident, then burning sensation in the affected area, immediate swelling, that is ballooning of the tissue in the area with a widespread with a spread to the surrounding loose connective tissue, profuse bleeding episodes. This bleeding episode can occur through interstitially or through the root canal system which you are operating. Then over the next few days, the pain will subside to a constant discomfort, but the swelling will be persisting for a week or more, and progressively start subsiding on its own. The interstitial hemorrhage may result in ecchymosis over the skin, which you can see in the picture. So the ecchymosis you can see in the picture occurring on the patient's face. So you can see the ecchymosis has led over to the face, crossing the border of the mandible, half of the face, even including the eye of the patient. It result then which may be affected, the affected skin will become discolored due to this. So how do you manage this hypochlorite accident, or what is the treatment modality? First one and foremost is to stop the treatment. Whatever the treatment you are doing, stop it. And explain the patient that this thing has happened and an accident has happened. And you should remain calm and always reassure the patient that everything will be good in few days, because the pain experienced by the patient will be very uh, excruciating. So there is no antidote per se for the sodium hypochlorite accident. Only we can do is provide palliative care to the patient. First one is stop the treatment, then immediately irrigate with copious amount of saline. How much ever you irrigate, you can try to reduce the concentration of sodium hypochlorite in coming in contact with the soft tissue. Then evaluate the airway of the patient, check whether the patient is breathing normally or any anxiety attack has occurred, or it has not affected any breathing. Once the evaluation of the airway is confirmed and everything is good with the patient's airway, pain control can be done. So how can we control the pain? You can immediately give a nerve block to the patient to prevent excruciating pain. Then prescribe some analgesics like naproxen, 500 to 1000 mg per day. The dose will be sufficient. Then you have to provide corticosteroids for at least 3 days. First dose you can use immediate IV. 4 to 48 milligram per day of triamcinolone and 8 mg of doxon IM can be given to the patient in next coming 2 days. Consider the incision and trephination if it is necessary to remove as much of irrigation of the area to remove the concentration load of the sodium hypochlorite with the soft tissue. Antibiotics can also be provided for 1 week, penicillin and metronidazole combination. Then patient can be advised to provide cold compress for the first 6 hours followed by warm compresses and mouth rinses for next 1 week. Then provide verbal and written home care. If a patient doesn't remember, better to be written home care instructions along with the verbal instructions are better so that the patient doesn't forget and they can and always set up a regular recall visits. After the accident, obviously, you need to call the patient on next day once the palliative treatment has been provided. Keep the patient on follow based on the progress of the patient. Then first, but apart from all the treatment, the first better is to prevent the accident. Best is the prevention. Prevention of the nerve extrusion, passing the apex is the best method to avoid such accident. Express intracanal irrigant slowly, provide needle placement in the canal passively, especially if you are using a beveled needle to for the irrigation purpose. Watch out the flow, backflow of the irrigant. See whether the irrigant is coming back into the chamber of the root canal or it is gone beyond the apex, which you can obviously assess while doing the procedure and always perform the treatment under rubber. Then sometimes some patients have seem to have hypersensitivity to hypochlorite also. So thorough medical history is essential to prevent such a this one. If the patient is unaware of such a hypersensitivity to the hypochlorite, you can always advise a patch test for confirmation. Adverse effects cannot only be related to the clinical toxicity but also to the allergenicity. In such patients, use an alternative solution like solvent. Then coming on to or moving on to the next irrigating solution that is hydrogen peroxide. 3% hydrogen peroxide was introduced by Grossman in 1943 as an endodontic irrigant. So O'Hara, Torabinajad and Catherine evaluated this 3% hypochlorite solution to other contemporary irrigants with respect to its antimicrobial efficacy and found it to be moderate to the anaerobic pathogen. So this hydrogen peroxide is considered to be good against anaerobic bacteria. So combination of sodium hypochlorite and hydrogen peroxide. This combination was transient, but an energetic effervescence was achieved by production of nascent oxygen. And this production of nascent oxygen is responsible for forcing of the debris and microorganisms out of the canal. So hydrogen peroxide does not possess any dissolving tissue dissolving properties, nor it acts as a lubricant. And antimicrobial effect is also very limited compared to sodium hypochlorite. So it is always coupled, better to be coupled with the solvent action of sodium hypochlorite or organic debris. So hydrogen peroxide was coupled with solvent action of sodium hypochlorite on organic debris. Baumgartner and eBay have explained that stoichiometric basis for the interaction of sodium hypochlorite and hydrogen peroxide are summarized as follows. Sodium hypochlorite plus hydrogen provided water plus chlorine plus sodium hydroxide. And this sodium hydroxide again reacted in the presence of chlorine, which led to the release of sodium chloride, sodium hypochlorite, and hydrogen peroxide. So this reaction is interchanging. So there is no actual free chlorine available at the end of this reaction. So the bactericidal activity of this combination of this product is actually these two material is actually questionable. So the combination has shown to inhibit actually the antimicrobial properties, whatever might be there along with the sodium hydrogen peroxide and sodium chloride, be nullified by each other. So when irrigating with hydrogen peroxide, the last irrigant use should be sodium hypochlorite to prevent any nascent oxygen from being trapped in the canal. because the hydrogen peroxide acts by releasing the pleasant oxygen. So, adverse sequel of hydrogen peroxide. Nehali and Neda in Israel reported the case of hydrogenic pneumomediastinum after irrigation with the hydrogen peroxide. Such a patient may present with pain, dyspnea, and fever, leukocytosis, swelling with uh, prophylactic antibiotics has been So whenever you see such patient with pain, dyspnea, and for the confirmation of this patient, chest X-ray is advised. Prophylactic confirmation is done using a chest X-ray. Prophylactic antibiotics is provided for around 10 days. Monitoring of the vitals of the patient has to be achieved to to assess the stability of the patient. Then another one is another adverse sequel of sodium hydrogen peroxide is ear emphysema. Symptoms include sudden severe pain accompanied by rapid swelling, crepitus, erythema in the region of the treated tooth. The most cases, emphysema during the root canal does not require any antibiotics or any other therapy. The emphysema in most of the cases will resolve in few days. So this is a photograph showing ear emphysema which has occurred in the patient after irrigation with hydrogen peroxide. Now coming on to the next, the gelatin medium, Naira Roots 1957 introduced EDTA. Ethylene diamine tetraacetic acid. So ethylene diamine tetraacetic acid is an insoluble, odorless, crystalline white powder which is relatively non-toxic and only slightly irritating in the weak solutions. The pH of this solution is around 8.3 and concentration used for endodontic therapy is 17%. It has a dentin dissolving effects desirable for all kinds of root canal therapies. It reduces the time required for the debridement of the root canal. It also aids in enlarging the narrow or obstructed canal because it dissolves the dentin. It also helps in bypassing a fragmented instrument, not and it doesn't have any corrosive action on the instrument also, unlike sodium hypochlorite, which might have corrosive effect on the root canal instruments. Antibacterial property cannot be stated because it is neither bactericidal nor bacteriostatic. The action of the sodium EDTA is self-limiting. EDTA forms a stable bond with the calcium and deposited solution can dissolve only certain amount of dentin. When all gelatin ions have reacted and equilibrium will be reached, then no further dissolution will take place. This effect is found to be rapid during first 1 hour of contact with the dentin and will reach equilibrium by end of 7 hours. So obviously the EDTA having a self-limiting action. Then what is the function of EDTA? Because as we saw, it doesn't have any bactericide or antibacteriostatic activity. It is mainly used for lubrication or emulsification of the root canal and removal of the smear layer. So it is available and can be dispensed in two forms, either viscous or aqueous form. Viscous is used for the lubrication and smear layer removal of the dentin during the canal preparation, whereas aqueous solution is used as a final flush after the shaping and cleaning of the root canal to remove the smear layer. Coming on to the antimicrobial effect, 17% significantly has better antibacterial properties as compared to the saline. As compared to saline, it has better properties, but compared to other previous 2, 3 so hydrogen peroxide or sodium hypochlorite, there is no action compared to them. So O'Hara, Korabina Kettering found that the solution to the antibacterial benefit after 60 minutes or 1 week exposure to the bacteria. So much long we will expose the material. No one can do such a long exposure of hypochlorite with root canal with the EDTA. So at the same time exposure time, so this amount of time is not very helpful during the root canal therapy. So P. gingivalis, the solution has good antibacterial effects against P. gingivalis. However, the other authors have proven that EDTA some possesses at best limited antibacterial property. Then what about the antifungal activity? It chelates the calcium ion, prevents binding of the Candida albicans. to a protein in a dose-dependent manner. So it removes calcium ions from the canal walls and thereby causes the canal walls to collapse. So also it inhibits the enzymatic reaction. So it actually, rather than inhibiting the albicans, it prevents them from binding to the root canal. Then EDT and the smear layer. How does it act against the smear layer? It is effective in removal of the smear layer, not along the coronal from the coronal aspect, but fail to do so in the apical third, according to Ram, who has done experiment using EDT and its penetration inside the root canal. Stewart and others introduced a combination of EDTA with urea peroxide in a base of carbovax, which is known as RC prep. This RC prep is commonly used during the root canal therapy. Later on, composition of RC prep was changed to replace the urea peroxide by 15% carbon peroxide. Goldman et al. Showed that sodium hypochlorite was capable of removing the smear while EDTA cleaned the canals effectively of the inorganic portions with organic material left behind. EDTA with cetrimide is also known as REDT. So actually, sodium hypochlorite removes the smear layer better than the EDTA, but the main action of EDTA, according to me, is fluorination of the canal. So this is the mechanism of action. Sodium hypochlorite EDTA provides in presence of soluble and fluorous acid. This is the reaction which is interchanging and sodium hypochlorite is used with EDTA. The second step accounts for the effervescence of hypochlorous acid, provides chlorine plus water, oxygen plus water. So suggested a 10 ml of EDTA 17% followed by 10 ml of sodium hypochlorite has an effervescent action on the root canal. So this combination is served and endodontist as a gold standard even for almost past 2.5 decades and meets nearly all the requirements of the ideal irrigant used while shaping and cleaning of the root canal. Goldberg and Abramovich state added that quaternary ammonium bromide acceptable to EDTA to reduce its surface tension and was called EDTA-C. So this addition increased the wedding effect of the EDTA of the root canal and permitted deeper penetration into the tubular irregularities. Then another combination of EDTA is EDTA-T, which was combined with sodium lauryl sulfate, similarly introduced to reduce the surface tension of the root canal. Atner and Bidke developed the EDTA and ethylene diamide, which is a strong organic solvent, and they found that the patent tubules in the canal in the coronal third and concluded that more research was needed for these two combination and assess their efficacy. Then demineralizing effect of EDTA, as there has been stated that it dissolves dentin. Curry and Bragato and Waldry evaluated the demineralizing efficacy of EDTA in different pH values and found that 0.3 m solution showed greatest demineralizing efficacy between pH 5 and 6. So it may imply that the intertubular dentin completely disappears between the tubules. Individual tubule opening in a close proximity. So 1 minute application, however, remove the smear layer without inappropriate erosion. So a related gelatin EGT glycol bis aminoethyl ether tetracetic was introduced and reported by Calt and Serper to have efficient smear layer removal without inducing dentinal erosion caused by EDTA. Then effect of time and the demineralization of the EDTA. So EDTA has been reported to remove the smear layer in less than a minute if it capable to reach the root canal surface. Since EDTA has a strong demineralizing effect, has helped in enlargement of the dental tubule, softening of the dentin, and denaturation of the collagen fibers. So this may affect the adaptation of the root canal filling materials into the canal wall. Yamada reported that a few seconds of EDTA to be sufficient, whereas Goldberg and Spielberg reported an optimum time of around 15 minutes to in contact with the root canal to achieve these effects. Card and Server showed that the 10-minute application caused severe peritubular and intertubular erosion. So because more erosion, the diameter of the openings are greater than the tubules themselves, which is known as wormhole appearance, which is a more seen into the root canal dentinal tubules as an effect of EDTA. Then effect of bond strength of EDTA on the treated dentin. If the dentin is treated with a combination of sodium hypochlorite and EDTA, that is RC plus significantly large reduction in the bond strength of the dentin is seen. Sodium hypochlorite has an oxidizing action of this agent leads to the oxidation of the dentin matrix that is critical during the composite polymerization. Whereas RC prep is a residual peroxide which breaks down the oxygen and water, and these form the bubbles or voids with the interfering the resin infiltration into the extra dentin. So oxygen is known and now that's already known as oxygen is the inhibitor of polymerization. So the peroxide may also oxidize the collagen and other matrix components, therefore interfering with the interfacial polymerization. Polyethylene glycol residues prevent the complete polymerization of the monomers to polymers, and therefore use of 10% ascorbic acid or sodium ascorbate is recommended. Polyethylene glycol residues prevent the complete polymerization of the resin by converting the oxidized substrate into reduced substrate, thereby restoring the redox potential of the dentin. Combination of nothing now we are seeing that the ETA is combined with sodium chloride and it has a very good proper effect of these two combination. But what about EDTA and chlorhexidine? So immediate formation of white carbonic precipitate is seen when EDTA is mixed with the chlorhexidine, and this precipitate involves chemical degradation of the chlorhexidine. So because of the degradation of the chlorhexidine is seen, so the antimicrobial property of chlorhexidine is not achieved when EDTA is combined with chlorhexidine. So coming on to other gelatin agents like tannic acid, so 25% is used as a cleansing agent was first introduced and suggested by Graham Mount. So it has an astringent property for coagulation by precipitation of the proteins. It is also known as to possess antimicrobial properties. No deleterious pulpal reactions have been found in tannin fluoride preparations. It caused an increase in dentin hardness because of its inhibiting effect on the calcium dissolution while organic matter in the dentin was reinforced. Constriction and obliteration of the dental tubules was observed by using tannic acid and dissolution of organic matter was inhibited, according to Tanizaki and then coming on to the other acidic ingredients like citric acid, 50% citric acid solution possesses antimicrobial efficacy equivalent to 5.25% sodium chloride against several anaerobic bacteria. A use of 10 ml of the solution for 5 to 15 minutes is recommended. A combination of citric acid and hypochlorite has also been demonstrated its antibacterial property in by Bob Nutter and eBay in 1987. Lowe described the foaming action of the combination which occurred on addition of hypochlorite to 50% of the citric acid. Acetic acid is has very acidic pH that is 1.2, where the initial reaction readily occurs to with a large amount of hypochlorous, which decomposes to form chlorine gas. So it removed the smear layer from both middle and the apical throats of the root canal and was equally effective on the removal of the smear layer as was the 70% EDTA. So definitely citric acid has more promising effects on the root canal. And then coming on to tetracycline, three combinations of this drug are used as an irrigant: the tetracycline, HCl, then minocycline, and doxycycline. These are the broad spectrum antibiotics which are effective against a wide range of microorganisms and known to enhance the healing of the periapical area after the surgical therapy. So low pH in concentration solution and those act as a calcium chelator. So this may cause a root surface demineralization comparable to citric acid. Substantivity of these antibiotics allows them to be absorbed and released gradually from the two substructures, and they also have ability to remove the smear layer, and few studies have suggested this ability of the tetracycline products. Doxycycline 100 mg per ml is effective in removing the smear layer if of the instrument canal, and 1% tetracycline could remove the smear layer as same as 50% efficacy of citric acid, but was found to retain the peritubular architecture of the dentin, which was not seen with 50% citric acid. Then coming on to chlorhexidine, it is a cationic bismuonide with the optimal antimicrobial action between pH 5.5 to 7. Leonardo et al. Has proposed. The concentration use of chlorhexidine include 0.12, 0.2, and 2% according to Hayes, Jana, and White. The commercially available oral resin typically consists of 0.12% of sodium chloride or chlorhexidine gluconate, 11.6% alcohol, glycerin, and flavoring agents like saccharin are used in this oral rinse. So, what about the antibacterial effect? It possesses a broad spectrum of antibacterial property against gram-positive and gram-negative, some fungi, bacteria, spores, lipophilic virus, and termitophytes. What is the mechanism of action of sodium chloride in high and low concentration? High concentration is bactericidal as it penetrates the cell wall and causes precipitation or coagulation of cytoplasm probably caused by cross-linking, whereas low concentration has only bacteriostatic effect. The positively charged molecules of chlorhexidine bind readily to the negatively charged walls or cell walls of the bacteria, mainly the phosphate group in LPS and carboxyl group in proteins. It therefore interferes with the membrane transport, initially leakage of low molecular weight substances. And it also acts by absorbing the cell wall of the microorganisms and causing leakage of intercellular components. So bacteriostatic effect is considered to be more important since the bound of the chlorine molecule is released slowly over the 24 hours of range. When 2% and 20% of sodium hypochlorite and chlorhexidine were combined, both showed an equivalent antimicrobial effect. Chlorhexidine is a base and capable of forming salts of a number of organic acids. Sodium hypochlorite, whereas it is an oxidizing agent, oxidizes the gluconate part of the chlorhexidine to glucanic acid. So the chlorine groups may get added into the gluconide component of the chlorhexidine, forming chlorhexidine chloride. So which results in increase in ionizing capacity of the chlorhexidine and makes the solution more alkaline. So the combination of chlorhexidine 6.5 pH whereas sodium hexylamide pH, whereas combination provides pH of 10 and is effective against these combination of sodium hypochlorite and chlorhexidine considered to be good against E. faecalis, which is the most important culprit for reinfections in the root canal treated or retreatment cases of the root canal or failure of the root canal cases. Buck and others have reported on the ability of the combination of chlorhexidine and sodium hypochlorite and alcohol to detoxify the LPS molecules, lipopolysaccharide molecules by hydrolysis within the canal. Heating of the chlorhexidine solution to 46 degrees centigrade enhance the antimicrobial action of 0.12% of chlorhexidine and produce a 1.8 log reduction of E. faecalis. Evaluation of the antibacterial properties revealed that these solutions to perform as well as routine antibacterial agents like nystatin and ketoconazole and found to be superior results to 5.25% soluble against antimicrobial, anaerobic bacteria. Then coming on to antimicrobial substantivity of the sodium hypochlorite. So root canals which are treated with the chlorhexidine results in molecule being absorbed into the dentin. So root dentin treated with the chlorhexidine has shown to acquire substantivity, which extends at least to a period of 7 days, and it has shown to be extended up to 12 weeks. So antimicrobial substantivity acquired by the root dentin after treatment with chlorhexidine inhibits the reinfection of the root canal and subsequent treatment. Antimicrobial substantive depends on the number of chlorhexidine molecules available to interact with the dentin. Therefore, the medicating the canal with the concentrated chlorhexidine preparation should result in increased resistance of the root canal against microbial colonization. Tissue dissolving property doesn't possess any tissue dissolving properties by chlorhexidine. Toxicity is characterized by relatively absence of any toxicity and their animal experiment also has demonstrated no reaction against foreign body. It is a foreign body reaction. Only moderate intensity reaction has been seen. So Jinson and White has reported its non-toxicity and suggested its use in cases of perforations, open apices, or difficult isolation areas where you cannot do rubber dam isolation. So chlorhexidine is combined with the sodium hypochlorite because it both has seemed to be a synergistic effect. So, but before combining this, and immediate you have to understand what are the chemical reaction if the two are usually combined with each other. So, immediate formation of a brown precipitate that is parachloroaniline PCA is tend to be a forming which immediately blocks the dentinal tubes. So PCA is directly increased with the increase in sodium hypochlorite. Toxic in humans with the short-term exposure resulting in cyanosis, which is a manifestation of methemoglobin formation. The combination of sodium chloride and chlorhexidine causes color changes and formation of possibly a toxic solid insoluble precipitate that may interfere with the seal of the root obturation. Alternatively, the canal can be dried using paper plates before final chlorhexidine rinse or by using an absolute alcohol or minimized by using saline as an intermediate irrigant is suggested when these two combinations are to be done. Then coming on to iodines, iodines, the two type of iodine preparations are used as an intermediate ingredients. That is povidone iodine and iodine potassium iodide. Povidone iodine is used as a 10% solution, which is also known as betadine. Iodine potassium iodide is used as a 2% solution. Betadine scrub is also available as which incorporates a surfactant. Thornake advocated the use of povidone iodine solution because the rapid antiseptic action against a wide range of microorganisms performs better on antibacterial efficacy as compared to calcium hydroxide. So, iodine potassium iodide achieve 100% sterility of 15-minute time frame, low toxicity, hypoallergenity, a decreased tendency to stain the dentin as compared to other iodine-containing antiseptics. Mechanism of action: iodine is strong oxidizing agent. It reacts to the free sulfohydryl group of bacterial enzyme resulting in the disulfide linkages, therefore effective against several root canal microorganisms. Also found to have low toxicity to tissue culture cells at 2% concentration compared to other intravenous medicaments except calcium hydroxide. Its antimicrobial effect is due to its vapor forming ability and low surface tension. Coming into salvizol, it is a derivative of auxin, that is 8-hydroxyquinoline, and have action against bacteria, fungi, and molds. It was introduced in dentistry in 1956 by Trotter for post-extraction infection. Salvizol belongs to the surface-acting material similar to quaternary ammonium group, and it differs from the uh, later by its antibacterial activity, even in the presence of organic materials. Material is well tolerated by the periodontal tissues. Root canal treated with 0.5% deep guaninium solution were cleaner than those treated with 15% in according to Kaufman. It has a detergent properties and it can penetrate into the places which are not reached by the instrument. So it has a better flushing action compared to EDT. It removes the organic material from the dental material and to a lesser extent the inorganic parts also. So effective even in apical bundle of the root. A related compound of this dequalinium acetate BDT has a solvidol. It has less antimicrobial action and but more cytotoxic also compared to iodine potassium iodide cytotoxicity. The antimicrobial quotient is higher than sodium chloride. It has ability to remove the smear is also was not different than sodium or saline except for slightly enhanced action in the apical water of the root canal. Dispensing forms it can be used as an irrigating solution or in 0.125% working solution of 0.5% and paste at 0.48%. The next one is electrochemically activated water (ECA) are produced from either tap water or low concentration salt solution. When electrolysis of the aqueous solution is carried out in electrochemically activated unit, an anolyte and the catholyte of the electrochemically activated water is produced and isolated. It is active state is available in 48 hours before the solution reaches a stable state becoming inactive and once. So the analyte has high oxidation potential and antimicrobial effect and pH of 2 to 9. Catalytic is alkaline in nature and high reduction potential and is reputed to have strong cleaning or detergent effect. So when the anolytic and catalytic are individually used as irrigant in infected canal, the antibacterial efficacy of this was disappointing when compared to 0.5% sodium chloride. So commercially available products include Stevolex and Catholite, Anolite and which opted and company and Anolite Stivolox solution and Catholite sodium hydroxide pH. So oxidized potential water, Hatha et al. Studied antibacterial and antiviral agent for the root canal irrigation. The oxidative potential was developed in Japan for household and agricultural purposes. Be defined as an electrolytically highly acid water having accumulated into the anode compartment after sodium chloride added water was consumed hydroxide ions. So oxidized potential water is strongly acidic in nature, pH of 2.5, and its oxidation reduction potential is 1050 millivolts and was against a 300 millivolt of tap water. Possesses several oxygen containing antibacterial constituents like sodium chloride and reduced oxygen. She also reported the cleaning. It has a healing action against the viruses which included HSV, HIV, and mouse CMV. The absence of toxicity and irritability caused by the immediate loss of high oxidation reduction, poor potential, and low pH upon reacting with the light and organic substances. It is safe for patients to hold in oral cavity. Volume used is 10 ml and the time is around 1 mm at least to produce this effect. It does not effectively remove the smear layer. Coming on to the ozonated water, we use powerful antimicrobial agent against the bacteria, fungi, protozoa, and viruses. Ozone in aqueous or gaseous phases has strong oxidative power with reliable microbial effects. Ozone destroys cell walls and cytoplasmic membranes of bacteria and fungi. Increased permeability leads to ingress of ozone, which causes microbial death. It has advantages like potency of handling, a lack of mutagenicity, rapid microbial effects showed less toxicity against EL929 loss fibroblast than sodium hypochlorite according to Nagayoshi et al. Disadvantages, but it requires continuous flow for its action and rapid ozone degradation in contacting with the organic compounds we see. Endofil is a natural product derived from the tropical plant Ricinus communis, castor oil detergent. Ferreira et al. Used endofil at 0.5% sodium hypochlorite as an ingredient and found former that is endofil to reduce colony forming units for animal organism better than in the periapical and necrotic tissue better than sodium hypochlorite and is so seen to be effective against gram-positive organisms only according to human. The mode of action is by formation or prevention of the biofilm adherence against between the canal wall and the bacteria. Glutaraldehyde was investigated as an irrigant because of its germicidal activity. However, it is also capable of reducing inflammation. Martin found 2% glutaraldehyde to produce extensive necrosis with only mild necrosis of 5% sodium chloride. Therefore, it has been never been a popular irrigant because of this action of glutaraldehyde. Then coming on to antidiabetes is a combination of an antibiotic with an acid and a detergent. It was introduced to a scientific literature in 2000. This irrigant was introduced by Toravina Garita Ali Global in the dental school. Its composition consists of an an antimicrobial agent that is tetracycline, mainly the antibiotic that is 3% and doxycycline hyclate, then acetic acid in 0.5% concentration and a detergent. The tetracycline provided broad spectrum antibiotic that is bacteriostatic in nature, low pH, then calcium chelator also, which results in surface demineralization similar to citric acid. Substantive property then promote healing of the tissues and remove smear layer, whereas citric acid of 0.5% was added to remove the smear layer and provide antibactericidal effect. And then detergent in 80 was added to reduce the surface tension so that other two remaining products will come in contact with the dent. MTAD and the smear layer, removal of the smear layer was achieved in 2 minute application with 5 ml of the solution. It also had antimicrobial property by disinfecting the root canal compared to 5.25% and is highly effective against E. faecalis after exposure of short time of 2 to 5 minutes. So protocol of clinical use of MDAD is 2 minutes with 1.3% sodium hypochlorite followed by 2 minutes of MDAD. And it has a capability to kill E. faecalis even at dilutions of 200 times, whereas sodium hypochlorite has restricted the dilution, is the dilution around 32 times. So it has also has solubilizing action, but it is lesser than EDTA and sodium hypochlorite. Cytotoxicity is less cytotoxic than eugenol, 3% sodium hydrogen peroxide, calcium hydroxide base, 5.25% sodium hypochlorite, peridex, and EDTA, but more cytotoxic than 2.63, 1.31, and 0.66% of sodium hypochlorite. So it has no effect on flexural strength of the dentin or modulus of elasticity of the dentin. Tetraclean is another product which instead of a quinated, another detergent is used as propylene glycol, and it has so doxycycline hydrate is used in 50 mg concentration per 5 ml rather than the 150 mg per ml which was used in peptide. Then coming on to another solution, that is the irrigation hurdle solution, which is based on a high PPM, a radiopic, high contrast injectable dye. 5% sodium hypochlorite plus high PPM plus 17% EDTA is known as a hurdle solution. So solvent action and reduce opacity similar to metaculture because of the hybrid. Penetration is achieved in the dental tubules because of the transtensive active agent which decreases surface tension. Besides removal of the smear layer, solvent action of sodium hypochlorite plus improved penetration due to the EDTA and radio opacity due to HAPAC is used to detect the presence of lateral of the accessory canals, but it is not used as an irrigant material. So these were the different types of irrigation solutions available in the market. Also. So we saw in detail about this. The next section will be, I think, better to be taken as a different part of discussion rather than in the same thing. So we will another video will be sharing at the after. Yeah, which will tell us about the parameters affecting the irrigate efficacy and different types of irrigating techniques and methods available in the